Welcome back from lunch, everyone. Thanks again for joining us today. For those who weren't here earlier, my name is Ken Sutha. I am use he, him pronouns. I'm a middle-aged Asian male who's bald and wearing a gray polo. I am co-chair of the Stanford Medicine Alliance for Disability Inclusion and Equity. In these afternoon sessions, we'll be taking a deeper dive into how people have been building community, and particularly with a focus on medical trainees. All right, next we'll have our next session 4, Cultivating Mentorship and Community Support for Disabled Trainees and Clinicians, with our moderator, that we welcome now, Dr. Ram Rao.
Good afternoon, everyone. My name is Ram Rao. Thank you, Ken, for that introduction. I am a pediatric oncologist at the Seattle Children's Hospital and a principal investigator at the Seattle Children's Research Institute. Really excited. And I use he, him pronouns. I am an Indian man in his early 40s. I have brown skin. I'm wearing black glasses, and I have a green jacket. And so I'm excited to moderate this session. We have amazing speakers ahead of us that will be presenting great work. And so our first speaker is Dahlia Chavez, who will be presenting Peer Power, Reframing Disability and Chronic Illnesses in Medical Education through Story, Data, and Collective Action. Thank you, Dahlia.
Hi, everyone. Thank you so much for the opportunity to speak here today. Can everyone see my slides? Great. Okay, thank you. So let me just say this. There we go. As Dr. Rao said, my name is Dahlia Chavez. I'm a medical student based in Chicago and one of the associate directors for medical students with disability and chronic illness, or MSDCI. I'm a brown hair Mexican-American woman with straight brown hair. Sorry, I'm a brown Mexican-American woman with straight brown hair, brown eyes, and I'm wearing a blue collared shirt today. Before I go further, I wanted to ground my talk in something personal and share my own story. I was diagnosed with endometriosis after college, about a year before starting medical school. I'm a first generation college graduate, the first in medicine in my family, and I moved from a small underserved area in Northern California to Chicago for school. When I started, I didn't realize I could qualify for accommodations, so I did what many students do. I pushed through. I showed up during flares, tried to keep up, and eventually that caught up to me. After struggling academically for a year, I was finally diagnosed with ADHD. I spent the next year figuring out the proper treatment for myself, and when step 1 came around, I ran into health concerns that made studying harder. I had to take a leave. I work full-time while studying to afford living expenses without financial aid and figure out how to move in a system that wasn't built for someone like me. And to be clear, my institution is not uniquely bad. It's actually very similar to many others, which is kind of part of the problem. My family has been incredibly supportive, but as a first in medicine, there are limits to the kind of guidance and financial support they can provide. So a lot of this has been navigating things on my own and trying to find out who can support me in the way I need them to. And I share this story not for pity, but because this is not a unique story. A lot of what I'm going to talk about today isn't new. It's just not often named. So these are experiences that are happening every day in medical education. Students are waiting months for accommodations, studying through pain, fatigue, and flare-ups, and often choosing silence to avoid stigma. And what's important here is not just that these things happen, but that they often happen quietly. Disability is present in medical education. We know this for sure. It's just not always visible. And I've personally experienced this and have seen other of my peers and other students who are doing everything right, studying, showing up, pushing through, and still falling behind. Not because they're not capable, but because they're navigating systems that weren't built with them in mind. And a lot of the time, no one around them even realizes what's happening. So today we're seeing more students disclose their disabilities, which is very important, but many still don't. And disability is still not fully integrated into how we think about diversity in medicine. The impact shows up in well-being, retention, and ultimately who makes it through medical training. So the issue isn't just access, it's how disability overall is framed. Medicine still tends to frame disability as something to overcome. So when students struggle, the default assumption is you just need to push harder, instead of asking, what is the system requiring that might not be equitable? And so what happens is students adapt either for better or for worse, but systems overall do not adapt. So what I'm about to talk about comes from the work from both data and lived experiences. Through MSDCI, we've gathered survey data from trainees, along with narratives from programs like our MSTCI restaurants, because data helps us understand what's happening and stories help us understand why it matters. Across institutions, we have found that the same 4 barriers show up again and again. We have inconsistent accommodations, financial strain, stigma, and gaps in faculty preparedness. And these aren't separate issues, they usually reinforce each other. So to get deeper into them, accommodations are often delayed and inconsistent. And what's important here is that timing is not a small issue. When support comes late, students are expected to perform without it until these systems are established and come into place. So these delays aren't just creating inconvenience, they directly impact academic outcomes and can result in longer time to graduation, greater stress over longer periods, and may even make a candidate seem as a riskier applicant for residency and fellowship programs. Financial strain is also one of the least talked about barriers. Disability comes with real cost, like testing, care for health and other outside things that you might need care for, time off. And when a student needs to take time off to study for a board exam, like myself, or for health reasons or for other reasons, that student no longer qualifies for financial aid and is left to figure out how to cover living expenses while also addressing the reason for their leave. And when systems don't account for that, support becomes something that exists in theory, but doesn't always happen in practice. So a lot of times stigma is shaping how students make these decisions about whether or not to disclose. They're not just asking like, do I need support? They're usually asking, is this going to affect how I'm evaluated? Is this going to make it harder for me to graduate? Will I be seen or labeled as less capable than my peers? And over time, that external stigma becomes internalized and you start to think, ooh, maybe I don't belong here. And we already know that imposter syndrome is very large and a large presence in medicine already. So students are navigating both the system and themselves while also dealing with this rigorous higher education. Faculty are also underprepared, and this isn't about like blaming them or saying that our faculty members are bad. Obviously we like to hope that they have proper and good intentions, but many of them were never trained in disability inclusion. So what we're seeing is well-intentioned people working in systems that don't support them either. So this can lead to inconsistent experiences depending on who a student interacts with. And again, if you already have imposter syndrome, talk maybe to a person that wasn't in a good mood that day or maybe was not the right person to talk to. It can discourage students from seeking other help and other supports. Disability also does not exist in isolation. It interacts with identity, race, socioeconomic status, gender, and geography. And these barriers don't necessarily just add, they multiply. So two students with the same disability can have very different experiences depending on everything else that they're carrying at that time. So this is, just further exemplify that point with the slide. So this is where we shift the conversation from a deficit to a more informed perspective. Because lived experiences improve patient care, adaptability builds resilience and pattern recognition, strengthening clinical reasoning. So disability is not just something to accommodate, it's really something that adds value to our patients. And this is where peer support becomes really powerful, not because it replaces institution, but because it removes friction. There's no gatekeeping, there's no long approval process. It's really just us trying to address those barrier or gaps in access. At MSTCI, we've developed some student-led models to fill these gaps. So some of these are rest rounds, peer coaching, and Shine tutoring. Our MSTCI rest rounds are structured spaces for rest and accountability. We try to approach things with no performance pressure and do what we can to mitigate that. And what we see is that reduced isolation and improved consistency is something that traditional systems often struggle to provide. So this space is usually just for a place for us to vent and kind of connect with other students who might be dealing with similar struggles and hopefully getting some answers to that as well. And overall, just trying to build community. So Shine, Students Helping Improve Neurodivergence Education, is a peer tutoring model designed for neurodivergent leaders. It's not something that we have implemented quite yet, but it's something we are working on establishing. So if you would like to connect or share your input or ideas, we would love to have that. So please connect with me after. But the idea is that it's a flexible, identity informed, and focused on long-term skill building, not just short-term performance. So overall, these models work because they target what institutions often miss: belonging, validation, and peer modeling, which overall is building confidence and directly impacting retention and self-advocacy within medical education, or at least this is our goal. And we know that institutional change is slow, but our students' needs are immediate. So peer models often become the bridge between what exists and what is actually needed. Although this isn't always sustainable when our students are expected to help other students when the system itself is unchanging. So I do want to say the caveat is that both are very important to work forward towards. And the interesting thing is we already know what works. We know peer mentorship is always great, more standardized accommodations, something that Docs with Disability has graciously provided many of our community with like their clinical accommodations guide, which is fantastic. If you haven't seen or heard of that, highly encourage you to look that up. Faculty development, we know works. And we overall know that the gap isn't knowledge, it's implementation of these resources, of these systems to better our overall medical education. So I want to pause here too and encourage you to think about your own institution. What is one barrier you've seen and where are students falling through the cracks? And here are some steps if you hopefully have thought of that in the last couple of seconds. But these steps can start immediately. You can start by building peer support and making that more unique to your own institution, reviewing accommodation systems and trying to see if there are ways or gaps that you can make it better, advocating for faculty training, partnering with student organizations like MSDCI, like SMATI. And not all of these require institutional approval to begin, which is great. Real change happens when we combine data and storytelling, students and faculty partnerships, and advocacy with structure and with a shared goal. So disability is not a problem to fix. It's a perspective that can transform medicine. And the question is not whether disability belongs in medical education, it's whether we're ready to actually center it. I urge you to think about what's one step that you're willing to take after today. I urge you to start. It can be small, but it is so important to start at your own specific corner of medicine and try to make change wherever that is for you. And I also want to briefly ground this in the work that we're doing with MSDCI. We're a national student-led organization focused on supporting medical students with disabilities and chronic illness. But more importantly, we function as a network, a space where students can connect, share strategies, and build solutions that don't always exist within their institutions. These core values guide how we approach this work. So we use community because connections reduce isolation, advocacy because systems don't change on their own, education because awareness alone isn't enough, and accessibility because inclusion has to be built, not assumed. And these aren't abstract, they show up in our programs that I shared earlier, like restaurants, Shine, peer tutoring models, etc. So to close, what I've shared today isn't theoretical, it's already happening, and the question is whether we scale it or keep expecting students to navigate these systems alone. I also have here, we have MSDCI National Merch if you want to support the cause. We have a QR code up there, and then we also have our listserv, our GroupMe, and we're happy, even if you're not someone who identifies as having a disability or a chronic condition, we are just an org that just supports medical trainees overall. So thank you all for the time and for hearing me speak and allowing me to be here.
Thank you so much for your wonderful talk, Dahlia. That was great. We will summarize all the questions and hold all those till the end. And so our next speaker is Jacob Nguyen, and he will be talking to us about belonging, wellness, and institutional culture, exploring the impact of peer mentoring on medical students with disabilities. Thank you, Jacob.
Let me share my screen really quick. All right, hello, my name is Jacob Nguyen. I am an Asian male with short black hair and I'm wearing a gray t-shirt. So I'm excited to present a pilot study that me and my team have been working on regarding disability belonging in medical education. So again, we're looking at belonging, wellness, and institutional culture, exploring the impact of peer mentoring on medical students with disabilities. So I first just want to introduce our team. So our principal investigator is Dr. Sabrina Wilhelm, and then we are accompanied by a group of MS2 peer mentors that are also conducting this research, Michael Draves, Candy Zhao, Christine Garib, myself, and Kendall Hoyt. And so for some quick disclosures, we want to confirm that we have no financial relationships or conflicts of interest that are relevant to the content of this presentation. And also the research being conducted is part of an independent academic project at the California University of Science and Medicine. and we have no external funding or commercial support. So for today, I'm going to be taking us through some background and context regarding the research question and our proposed study. And then I'll be going into our study design and the objectives, talk about the significance and ethical considerations of our preliminary results, and then I'll be talking about future directions. So first, what is the current landscape of disability awareness? So overall, there's a high disability prevalence in the general population, and we've seen that from a CDC report of 26% of US adults identifying as disabled. And as such, we believe this diversity should be ultimately reflected in physician training. However, when we go to the medical school landscape, we see low disclosure rates. About only 4 to 6% of medical students choose to disclose a disability, and a lot of that is compounded by fear, stigma, or academic penalty. And another important component that we want to recognize is there are a lot of unmet psychological needs within medical student populations. Approximately 25 to 30% of students meet depression criteria, yet less than 1% disclose having related psychological conditions. So we want to recognize that as a compounding issue in this current landscape. And so overall, what we're seeing when it comes to disability awareness in medical education is that there's low disclosure rates, and that ultimately leads to isolation and lack of institutional support, which further leads to increased risk of burnout within medical students with disabilities. And so that brings us to why this study is needed. We want to recognize that medical education is very rigorous, and a lot of the time students are needing increased support than they did in the past. And so with disability being underrepresented, it's one of the most underexplored diversity domains in medical education. And so we do recognize that there's an institutional need with students reporting lack of community and visibility. And we want to also note that compliance with inclusion and equity guidelines doesn't necessarily mean an institution is creating equal inclusion among their community. So there's also a literature gap specifically when it comes to peer mentoring. There is data out there, but there's minimal data specifically with how it impacts belonging and wellness among medical students on campus. So our goal is to provide evidence for a scalable disability affirming mentorship model in medical education. And so for our study, we're really looking at 3 domains, the first being sense of belonging, the second being psychological wellness, and the third being perceptions of institutional inclusiveness on campus. And our study was conducted completely at the California University of Science and Medicine in Colton, California. And again, our objectives is to directly analyze those 3 domains I mentioned. And so currently our project is still in progress. So we're still collecting data, but all the content presented in today's presentation reflects the interpretation of the limited data that we've been able to collect thus far, and also the expected outcomes of the proposed methodology. But we are very committed to ethical compliance and protecting our participants. So that has been central to our study's integrity. So our pilot study used a mixed methods approach. So first, we were targeting to recruit 30 first-year medical students with disabilities. And our hope was that we would recruit 15 students that did have peer mentors, and then also 15 students that did not have peer mentors, so we could compare those 2 subgroups. And we used quantitative tools, these 3 forms: a psychological sense of school membership scale, PROMIS well-being forms, and the inclusiveness items. And these helped to analyze the 3 domains that I mentioned earlier. And so we also use qualitative tools. We had semi-structured interviews with 3 to 4 core questions, and participants were recruited via email and compensated with a gift card upon completing their session. And so when it came to analyzing the data for the quantitative data, we used descriptive and comparative analyses using SPSS, and then thematic coding for a qualitative analysis of the interview questions. And so to prioritize the prioritize the participants, the interviews were conducted by our PI. All data was de-identified, and students had complete voluntary control over their interviews with confidential participation and the option to withdraw at any time. And so our expected results were that the mentored students would display a higher sense of belonging and wellness, and that we would see themes of reduced stigma, stronger identity affirmation, increased trust in institutional support, and overall just see mentoring as a protective factor against isolation, particularly within first-year medical students with disabilities. So our early results show we were able to recruit 10 participants thus far. 5 of them chose to disclose a disability, with 3 of them disclosing an ADHD diagnosis, 1 disclosing a chronic condition, and another one disclosing an unspecified disability. And out of those 10 students that participated, 2 of them were participants in our pilot leads mentorship program at CUSM. And so we want to make note that currently we don't have enough participants to make comparative statistical analysis, but we did analyze the overall participant population so far. And so when we look at the Likert scale scores for belonging, wellness, and inclusion, they're all hovering right above 4, with around a standard deviation of less than 1. And so some qualitative themes that we're seeing so far are an overall sense of reduced isolation, increased support, with opportunities still to enhance disability and visibility, along with learning flexibility, as there's still room for improvement based on these scores. So moving on. So overall, our early results and our projected results hope to address gaps that can drive institutional change. Like we said, we want to fill the national gap, as there are a few empirical studies specifically that document the impact of disability-specific peer mentoring in the medical school setting. But we want to contribute to that body of work, which is currently an under-researched area of equity in health professions education as a whole. And so we're starting as a CUSM inclusion initiative, so at the local level, but hopefully eventually we can contribute to the formation of a scalable national model that can develop an evidence-based model to be replicated at other medical schools as well. And most importantly, we want to position disability as a valued dimension and valued perspective in medicine. And so that is ultimately our goal. So some considerations for our project is that, again, we were protecting vulnerable data with everything being de-identified and carefully monitored. We also believe that we have enhanced validity through our mixed methods design, as it combines quantitative and qualitative data measures. And again, we want to frame mentorship something that is an equity intervention rather than something that's remedial. It's not meant to be remediating individual deficits, but rather just foster a greater sense of inclusion. And then some inherent limitations of our study is, again, we have a small sample size. We're currently aiming for 30, but at the moment we have 10 participants. So that's currently limiting our statistical power. Our study duration is also short term. It only is evaluating first-year medical students, but is not longitudinal. There's also risk of self-reported bias in interviews and also surveys. And also we are a single institution, so there's limitations into how we can apply the findings on a broader scale. So our core conclusion is that mentoring will boost mentees' sense of belonging, wellness, and perceptions of institutional inclusivity, as those are projected conclusions as well. And we project to have anticipated themes of reduced stigma, stronger identity, and increased trust in support systems. So the long-term goal is to validate mentoring as a key equity strategy that can be used in medical education. And so for future directions, we hope to expand to multi-institutional studies, be able to implement more longitudinal tracking that can analyze how mentoring impacts mentees over time, and also integrate mentor training into DEI curriculums in medical education, but also other health professions. And so hopefully these things will lead to more actionable impact in implementing these disability-specific peer mentoring frameworks, and also disseminating these findings to drive national policy changes in medical school accreditation. So here are references. And I also want to acknowledge the CUSM Leads Office, which is our Learning Environment Equity and Disability Service Office, which we formed this pilot study under. I also want to thank the mentors for volunteering their time, as well as the mentees for their willingness to participate and share their journeys of belonging and wellness. And so again, thank you for supporting inclusion and belonging in medicine.
Thank you so much, Jacob. Wonderful talk. All right. Our next speaker is Kiki, who'll be talking about reimagining disability inclusion in healthcare, the development, implementation, and outcomes of multi-level dyad-centered disability mentorship program for current and future health professionals. Take it away.
Thank you so much. Thank you so much. My name is Kiki Schmalfuss. I use she, her pronouns. I am a white woman with long brown hair. I'm wearing glasses and a light blue shirt. I'm a current third-year medical student at Harvard Medical School and a co-founder of the Harvard Medical School Student Alliance for Chronic Illness, Health Conditions, and Disabilities mentorship program for current and future health professionals, which I'm so excited to talk to you all about today. When we were creating this program, we were really trying to understand what are the needs of our community and how can we best design this program to meet those needs. At the time, there was no existing formalized mentorship opportunities beyond kind of more casual student groups like ours at Harvard. And so we really wanted to see how we could fill that need. We asked students in the undergraduate and graduate schools how they felt about their disability and chronic illness identity in relation to their school and training, and 77% of the survey respondents indicated they were worried about how their disability and chronic illness would impact their school and training. We also asked a similar question, but including also health professionals, and 70% of individuals indicated that they were worried about the impact of their disability and chronic illness on their careers. And so for us, that really identified that there was a need for both the undergraduate level, in the graduate level, and also in the health professional space to support individuals with disabilities who are current and future health professionals at the Harvard community at large. For our program, we designed it to be dyad based. And so for those pairings, people who are eligible were pre-health undergraduate students, graduate health professions students, and current health professionals. We really wanted to ensure that this was encompassing health professionals of all kinds and not just medical students, even though our student group is housed in the medical school, to really kind of support health professionals with disabilities in all aspects of the health careers. Individuals who are interested could fill out an interest form at the beginning of the year, and then our disability resource professional, Tim, on the team went through those interest forms to see kind of people's backgrounds, what they were interested in getting out of the program, and paired those people individually together for best fits. So what those pairings ended up looking like is pre-health undergraduate students could be paired with mentors who were graduate health profession students. Graduate health profession students could provide peer mentorship to each other. And then graduate health profession students could be paired with current health professionals as their mentors. This program went from August of 2024 through June 2025 for this initial pilot year. And throughout this year, we also had longitudinal programming, including 3 different events and panels with the goal of bringing everybody together, supporting kind of disability community at large, and also equipping individuals with leadership and self-advocacy skills through some of these events. We asked that pairs meet up at least twice during the year, and this could be virtual or in person. We were able to provide financial support to reduce some financial barriers that might be at play, especially for in-person meetups. And we had individuals who, once they were part of the cohort, they filled out an initial survey to better understand where were people at, why were they joining the program, and how could we make this year meet their needs. And then we also asked people after they met up to fill out a post-meetup survey so we could better understand how often people were meeting, how it was going, and what people were talking about. And we also had individuals fill out an end of program survey to see how the program actually went. All these surveys were voluntary, and the data I'll kind of present is based off of these different surveys, but not everybody filled it out since it was voluntary. So for our participants, we ended up having 43 distinct participants across all those different categories I mentioned earlier. They ended up making up 25 pairs because people fulfilled sometimes multiple different roles. And the disabilities being represented most commonly was almost 50% chronic illness. Physical disabilities represented 17% of disabilities, psychiatric disabilities 15%, and then neurodivergent sensory disability, learning disability, and some other were also indicated as being represented in our cohort. When in that initial survey, we asked mentees why were they participating and what was most important for them for their participation. We offered them a list of options, and then they could rank things from not important at all to most important. So their most important, their top 5 most important reasons included to prepare for a career in health with insights from a mentor who has faced similar challenges, to receive guidance and support from someone who understands their specific lived experiences, to learn strategies for managing their disability or chronic illness in different settings, to form a personal connection with someone they can relate to, and to build a network with peers who have had similar experiences. We also asked this question of mentors, tweaking the kind of options a little bit to be more mentor specific. And the top 5 reasons that mentors indicated for participating included to provide guidance and support for someone who shares their specific lived experiences, to share their experiences and strategies for managing a disability or chronic illness in different settings, to increase disability representation, awareness, and inclusion in the health professions field and at their academic institution or workplace, to build a supportive community and network with peers or colleagues who have had similar experiences, and to form a personal connection with someone they could relate to. When we looked at individual meetups, we had 40 documented meetups from those kind of post-meetup surveys I had mentioned. We suspect that the number was actually much higher since not everyone filled it out after each meetup. But pairs indicated they met between 0 and 5 times, with most often being 2 meetups for the year, which was what we had suggested as the right amount. Some barriers to meetups that people indicated included scheduling conflicts, lack of time, and one person indicated lack of communication and unresponsiveness, as well as that their assigned mentor and mentee was not a good fit for them. So we wanted to understand better, how is our program impacting the Harvard community at large? So we asked all participants some questions about how strongly or not they agreed with a variety of statements to better understand that impact. So 88% of individuals strongly agreed or agreed that the program brought awareness to disability as an aspect of diversity. One person indicated they neither agree or disagree, and one person disagreed or strongly disagreed. I just want to note throughout this, the person who disagreed or strongly disagreed, unfortunately, was not able to meet with their paired mentor due to a lack of response on the mentor's part. 94% of individuals strongly agreed or agreed that the program equipped health professionals with confidence and knowledge to navigate a disability identity in the health field. Again, 94% of individuals indicated they strongly agree or agree that the program fosters community among students and faculty. And 94% of individuals also strongly agreed or agreed that the program increases the sense of support and belonging for people with disabilities and chronic illness at Harvard. So we really felt like this showed for us that the program was really meeting our goals for community impact at large. We also asked mentees more specific questions for how the program impacted them personally. And of those mentees who responded, 89% indicated they strongly agree or agree that the program increased their confidence in navigating disability-related services at Harvard, and one person disagreed or strongly disagreed with this statement. And again, unfortunately, this person was unable to meet with their paired mentor due to a lack of response. 67% of survey respondents had indicated they strongly agree or agree that the program increased their sense of disability and chronic illness pride. 2 individuals indicated they neither agree nor disagree with that statement. Again, 67% of individuals indicated they strongly agree or agree that the program increased their confidence in how and when they choose to disclose their disability or chronic illness, and 2 individuals neither agreed nor disagreed. And finally, 67% of individuals, again, strongly agreed or agreed that the program increased their confidence in becoming a health professional, and one person indicated they neither agreed nor disagreed. So we felt like this also was really in line with our goals of impacting mentees individually and improving their self-efficacy and confidence and kind of pride in their disability identity. So we're really thinking about now, after this pilot year, next steps and future directions. For us, the program was a huge success. It met community needs. It met our goals that we had at the beginning of the program, and really showed that our survey results had showed too that it had a positive impact both on individuals, but individuals who participated felt like it had a positive impact on the Harvard community and climate as a whole. And we did continue the pilot program the following year, so it's in its second year currently right now. We've really found also that this longitudinal programming piece was actually essential for the broader community impacts and a sense of increased inclusion. And we identified as kind of a spot to keep working on, that a clear process on how to address issues is necessary for success with this program. For example, with unsuccessful pairings and lack of responsiveness that one individual experienced, understanding a better way to address that for the future. And something we're continuing to think about is how to make this program meaningful and successful with fewer financial resources available since our pilot program has ended. Specifically for us, thinking about financial barriers to dyad meetups, especially in person, since we were able to fund those the first year, and also funding of longitudinal programming, since that was such an essential part of our community impact. So I just want to acknowledge our amazing team, Lily, Kelsey, Tim, and Dorothy. This program would not exist without them. And we also wanted to thank the Harvard Office of Diversity, Equity, Inclusion, and Belonging's Culture Lab Innovation Fund for funding our pilot program and making it possible. Thank you all so much.
Thank you, Kiki, for that wonderful talk. And we will move on to our last speaker, Kara Coates, who will be talking to us about building disability inclusion in healthcare, the journey of the Ohio Health Dawn BRG.
Thank you very much. Let me just get. Okay, thank you very much. I really am very honored to be part of this conversation today. I am a white woman in my 50s. She, her are my pronouns. I have brown hair with blonde highlights and blue eyes, and I'm wearing a gray cardigan. I am an advisor for provider and associate well-being at Ohio Health, which is a health system in the state of Ohio. And I'm also the chair of the DAWN BRG, which are two acronyms that I want to explain. So DAWN stands for Disability Awareness Wellness Network, and BRG is Business Resource Groups. Some of you maybe know them as ERGs, Employee Resource Groups. A little bit before I begin about our Dawn journey, but just to tell you a little bit about Ohio Health is we're based in Columbus, Ohio, but we are spread across Ohio in a 50-county area. We have 16 hospitals and many ancillary care sites, and over 35,000 associates, physicians, and volunteers that make up our health system. And Ohio Health's disability journey started in 2004, where we established a disability task force. And really our goal was to position Ohio Health as a workplace of choice by attracting, developing, and retaining a diverse and skilled workforce. And along that journey, we created our ADA policy, we hired a workplace accommodation specialist, and we created deep relationships with community disability-focused agencies. And then in about 2017, our inclusion and belonging team, that's part of our HR department, brought forward developing business resource groups. Ohio Health has 11 total. 2 are not on the slide currently because they are brand new. But business resource groups are associate-led, and they're formed around a primary diversity dimension. So it could be race, sexual orientation, gender, and in the case of the Dawn BRG, disability. And our members developed kind of the who we are and what we do, our founding members when we came together. And so, we are committed to promoting disability awareness throughout our health system. And our mission is to foster inclusion through educating, building that awareness, and developing disability competencies to create a supportive environment for all who are touched by Ohio Health. We have 90 members currently, 90% are female and 10% are male. And this is kind of the timeline of when we started. We kicked off the Dawn BRG 1 month prior to the pandemic. So for about 2 years, as you can imagine, we really it took a while before we could really recruit and create that community. But what we're really proud of is at that start of our timeline, there was a need identified when we were wearing masks where people couldn't read lips, and became a barrier in communication for that community. So we really worked with some of our members worked with our supply chain to source out clear masks and get those out to our communities. And so even though that we had to have this pause because, we were supporting our community through this pandemic, we were glad that our BRG was able to kind of really advocate and get those clear masks to everyone. So really our building year came in 2022, and this is where we did a lot of recruiting, a lot of educational campaigns about what Dawn is, and really focused on like what did we want our goals to be. And that's when we decided we really wanted to get a lot more education and awareness out to our system. And we decided to do that by having a signature event. And we coincided our signature event in the month of October because it's National Disability Employment Awareness Month. And so that is a national campaign. We thought we didn't need to reinvent the wheel because they had amazing videos and graphics that we could utilize as part of our event. And we also went with their national theme. They have a new theme each year. And so for 2023, the theme was Advancing Access and Equity. It went over so well. We also have an intranet site, and so we house recordings of all of our meetings and all of our signature events so that those that can't actually be there in attendance, whether that's in person or virtual, can still access on demand. And so that event went over so well. It focused a lot on education. That in 2024, we did the same focus in October for National Disability Employment Awareness Month, did the national theme of access to good jobs for all, and really did a focus on invisible disabilities. But really what I wanted to focus on is our event from this past fall in 2025, which was, again, on the national theme of celebrating value and talent. We had 135 people attend, both in person and virtual. And again, it is housed where people can see the recording. And we, through our signature events, really wanted to make sure we were becoming a model for all events at our health system. So how do we make sure that every event, without anyone needing to ask, has an ASL interpreter, that we have ramps that connect to the stage for mobility access? And what we really wanted to make sure that we also did was focus on the storytelling. All of our events, that seem to be what people really seem to gravitate to. And so our event kicked off with 2 of our executive sponsors, the president of one of our trauma hospitals and the vice president of our revenue cycle, kicked it off along with our CEO, Dr. Steve Markovich. And their words were super inspiring and powerful, especially coming from the top of the organization. Our CEO stressed the importance of inclusion, and it was the first time he attended and spoke at our BRG event. So it was really, really powerful for not only the members, but the rest of the organization to see that kind of support. And so we featured 2 stories at this event. And the first story was on our Project Search graduates who then got hired on at Ohio Health. Project Search is an international program that connects high school students who have physical or developmental disabilities with employers. And so Emily and Lloyd came on stage with their supervisors. Emily is a radiology tech assistant, and Lloyd works in nutrition services. And they both came and talked about how their supervisors created a really welcoming, safe, and engaging environment for them to have success at Ohio Health. Their supervisors in turn shared the value that Emily and Lloyd brought to their teams, and also kind of gave tips to other leaders that were in the room or even peers on how everyone can create an inclusive environment for all. And then our other story centered around a patient that came to Ohio Health. He has a high-level spinal cord injury, and it was about him talking about how the Ohio Health care team got him back to his career as a really successful realtor, and how they empowered him and gave him the skills and ability to keep going in his career. Again, this is National Disability Employment Awareness Month, so we wanted to show not only how we support our associates with disability inclusion, but also what we do for our patients to make sure that they can lead rich and fulfilling lives. The other thing we did before this event started, 2 hours before, is we had an expo, and this was the first time we did an expo. There were 20+ vendors that came, and people could come and have real intimate one-on-one conversations. Some of our external partners were Adaptive Sports, an ADHD coach, an organization called A Kid Again. And then we also had internal partners, which was our Neuro Wellness Center, along with our well-being team, our workplace accommodation specialists. And we also invited other business resource groups to be a part of this, just showing that we are all needed to create that inclusive culture and environment. And so these were just some of the other booths that were there. And then we did a post survey after this event, and 95% said that they gave it a highest and great experience rating. 90% said they learned something new from the experience. 98% said they are comfortable engaging in external and internal resources around a disability inclusion. And then we asked them to list one thing that they would do differently. And there were 3 themes that came through. One was they wanted to try and understand team members' disabilities better. To listen more, and to look for more opportunities to encourage inclusive behaviors at their own workplace and care site. And then we asked for their biggest learnings, and 3 themes that came through there were getting to know associates is a powerful way to be inclusive, learning the different ways Ohio Health supports persons with disabilities, and the support for disability awareness and inclusion from the top of the organization. That was super powerful that day. And then our intranet is where we have a lot of our education and connections to resources, along with all the recordings that I spoke about. And we are continuing to evolve and looking to see what we can do and continue advocacy, within our health system. And I really learned a lot from Dahlia and Jacob and Kiki's presentations, because it's making me realize we need to be a little bit more intentional of our medical residents and reaching out to them and making sure they're aware of our BRG and getting engaged with us. So I wanted to thank the 3 of them for the information they shared today. And then one of our members, all of our members get really passionate about creating disability inclusion. And I just, I don't want to, based on time, can't read everything that Marianne wrote in the spoken word of a tree is the tree has a broken branch, but I wanted to read an excerpt. She said, "Before I became a nurse, I was a fish geneticist. I did research and extension in breeding fish and other aquatic flora and fauna, so they will be of trophy size, look good and colorful. With many years of hard work, I figured that despite many trials to breed bigger and better aquatic living things, some remain small with some innate problems and not as aesthetic as others. What I admired, however, was that despite differences in a school of fish, they harmoniously swim and share their habitat with others. Each of us are unique, distinct, and unduplicated." And our biggest learnings is the passion we have received from all of our associates and how they really want to lean into creating that inclusive workforce and just getting better and advocating for everything that we can do possible. So thank you for allowing me to be part of this today.
Thank you so much for a wonderful talk. Thank you again to all the speakers. I'll start collecting the questions in the Slido. Please, if you have anything to add in there, I'll start asking them towards the speakers. But I wanted to kick something off, and hopefully everyone can kind of answer this question, because the common theme was mentorship and creating this community and sense of belonging. And one thing that Dahlia had in her presentation was to take a minute and to just think, what can we do tomorrow, today, to fix the system. And something, that's very clear as Kiki was presenting her data, was that, mentorship is great, but it takes time, it takes effort, it takes energy, right? And Jacob was talking about this as well, and so was Kara. So I guess, I am now faculty, right? And I am now on that side of finding the importance in being a mentor to others and helping people through the system. But what I am struggling with, and I'm sure others do, is I don't have any FTE for mentorship. I don't have any dedicated time as part of my responsibilities to be an excellent mentor. And obviously, I'm going to do what I can, but how do we today, tomorrow, help change the system so that mentors do have that protected time to help out and to serve as that guiding light to people going through a rough time? And how do we support and change the system accordingly? I was hoping to get an answer from everyone if possible, and that'd be great.
I know I can speak. I'm a talker. But I can definitely say, a lot of my like really effective and meaningful mentors have come to me on accident and more just like making themselves known. So for example, I'm really close with the DEI officer at my institution. She's fantastic, and out of desperation, I just was like, DEI, I'm Latina, let's go try there. And she has been lovely. And I will say a lot of that has literally just been, I didn't know what to do and I needed to ask questions and found her. I will also say like some institutions, and I'm sure you probably have this on yours, have like built-in mentorship where you are as a student assigned to a faculty member who can help guide you. Um, and sometimes that can be, good or bad depending on how the institution does that. And I will also say, um, I think the biggest thing I would urge is just if you see a student that's obviously struggling, instead of labeling that student as, oh, this person is not trying hard enough or anything like that, like maybe just literally pulling them aside or sending an email and saying, let's have a protected, meeting outside of business hours or whatever. And sharing, like, I am not going to share what you share with me. This is just offering my mentorship. Like, how can I help support you? And I will say that will probably get you more information from that student rather than just, I don't know, it's hard when you're like forced to meet with someone rather than it just coming naturally. And like, if a random faculty member were to reach out to me and it's like, oh, this girl's obviously struggling with something. And if they were to reach out directly, that would make me feel a lot more comfortable. Like, oh, someone is noticing I am struggling and I don't know what to do about it. And I would feel more inclined to share. So hopefully that answers your question.
At our health system at Ohio Health, we have a same-day support number. So if someone is struggling with whatever they're struggling with or in distress, it's no cost, and they can call a number and get connected to someone in same-day support. And then based on what they're struggling, that person is a professional on the other end that one keeps it confidential, but also connects them. It could be connecting them to a BRG, it could be connecting them to peer support, it could be connecting them to a counselor, but just getting them the help they need. And that's something that has been really helpful for our health system.
I think for me, even though I, spent a lot of time talking about a formalized mentorship program, the most important mentorship I think actually comes in like one-on-one interactions, kind of how Dahlia was saying also. And I think it actually can be very meaningful to students, trainees, but even current health professionals to take the moment to ask like, hey, are there any access needs that you have, like accommodations? Is there anything I can do special to support you on this rotation or, this experience? And kind of just the way you even approach things differently of like, oh, is it okay if we do you want to take the stairs or the elevator, or let's just take the elevator, for example. And those little things I think actually change a lot about the culture, but also let students know, this person is somebody that is supportive of me and is just creating an environment that is supportive. And that doesn't necessarily mean you have to go out of your way to be, spend hours being a formal mentor, I think.
That's definitely like a tough question to answer, but I would just say I think it's important to make resources readily available. I think a lot of what I've seen on the medical school campus is that people won't necessarily reach out for resources or if they need help. So putting that out there, whether or not if it's reaching people, I think just being proactive on that front and just having dedicated programs in place for that. Like for example, my school just recently had our leads department created for disabilities, but that didn't exist last year. So it was a much smaller thing. But now where we have a specific department dedicated towards that, to just providing resources and spaces, I think that provides great accommodation for our students. And obviously, hopefully, like even at the education level, there's still a lot of work that needs to be done. And so of course it's even harder at like, in the residency level or in the workplace. So hopefully the work that we do now can trickle up in the future. But
Thank you all for that, for your answers. We've got about 5 minutes, and we'll go through some of these questions. So to Kiki, question for you is, how did you pair mentors and mentees, and how long did this take? How will you promote the program's sustainability?
Yeah, so for the mentorship pairing process, we had the internship forum was open for about a month to let people fill that out. And then it did take about a month and a half, I would say, to get the pairings all set up. And Tim, the disability resource professional who's on our team, he spent a lot of time being very diligent about making those pairings very intentionally. And so that going through all those responses took about a month and a half for him, I would say, to do. Um, and then for sustainability long term, that's something we've been thinking a lot about. So the pilot program was funded, and then now this year, for example, it wasn't funded. So we've had to really rethink how to do everything without having financial support. And so we've had to cut down on some of our programming. We haven't been able to offer money for meetups. And we found it's still actually pretty successful, although we've had less of the longitudinal programming as a result. So we're honestly still trying to workshop that and really leaning on community support and institutional support in different ways to continue the program. And it lives currently in the our student group. And so we're hoping to kind of continue that on as different generations of med students come through. They can kind of hold a leadership role in leading that in the future.
Thanks. This question is for Jacob. For the pilot study methods, thematic coding, what software did you use to help you define the themes?
so for thematic coding, what I was really referring to is a more manual process where you like sift through the text of the transcripts and identify key themes that we're seeing and organize based on that. So it's not something that we've needed to use like a computer software for yet, but yeah, so it's a more of a manual process. Hopefully that answers the question.
Thanks. I believe this question is for Dahlia. Please explain your opinions on how impairment differs from disability.
That's a really great question. I think it's honestly just framing and perspective. It's really specific to what it is. Because I think any disability can really be labeled as impairment, even if it's not necessarily, but given the right tools or resources or systems in place, I think an impairment can for sure be something that's both, if that makes sense. So, for example, if someone has a visual impairment, I know plenty of physicians that are still great providers, and maybe just do a field of medicine that maybe doesn't specifically work like with needing that vision, like a strong sense of vision, or if they are given the proper tools to be able to make up for that. I don't know if that answers the question, but I really feel like that it's more just like a perspective and just a different label.
All right. And then one thing that maybe I can comment on here, how do you keep mentorship conversations confidential? I found that when students report behavior that constitutes abuse, harassment, or worse, mandatory reporting comes in because schools often retaliate against students who report, even if they don't do so officially. So that's a weighted question and has a lot to it. But I think, some schools and I was a fellow at Stanford and I can speak about this. Stanford had a mistreatment committee for medical students where they could file anonymous or named reports. And, I think what I learned from that is I was actually the only House staff member on that committee, and I served on that for 3 years. And I think having a disability, obviously, I could bring those insights in my lived experience to those reports. And so I think one way to prevent having this culture where students are retaliated against for reporting things is that we simply have more representation. We have more sense of belonging in all of these committees, right? And as everyone has said, disability is part of diversity, and we need to make sure that there are representatives on these committees. So I think that brings us right at 1. Thank you all for your wonderful talks again, and thank you for this wonderful conversation. Please feel free to put more things on Slido, and so our speakers can see how wonderful they were, and feel free to reach out to any of us in any capacity. Thank you all.
Thank you, Dr. Rao, and thank you for all of the great speakers in this session. Next, we'll go to our session number 5.